Abnormal uterine bleeding is a term we use to refer to any bleeding that is not normal. It can be abnormal in amount, in frequency, or in duration. It's a very common occurrence, and in fact, some people theorize that 1/3 of all outpatient GYN visits are related to some type of bleeding problem that the woman is experiencing. It's very important to discuss it with your doctor because of the impact it has on the quality of your life, the productivity of your life, not only at home but at work. And a woman who has to stop what she's doing if her bleeding interferes with her daily activities, then that should not occur. In this day and age, we have lots of treatments that we can offer a woman to help her with her bleeding problem, and she should not have to suffer like that. Some of the causes of the bleeding that we see could be structural, involving abnormalities of the uterus, or such as fibroids, or the cervix like polyps. Then we also look at reasons like ovulatory dysfunction. Also, medications can cause a woman to have abnormal bleeding. We have causes that are systemic, such as diabetes, kidney disease, liver disease, thyroid dysfunction. And of course, we have to consider other more serious causes such as cervical cancer, endometrial cancer, as possible causes for her bleeding. Evaluation of a woman that presents complaining of some problem with her periods involves a detailed history and physical, and then we frequently will get a pap smear. That's to make sure there is no cervical disease. She may or may not need an endometrial biopsy to make sure there's no abnormal cells up inside the uterus. Imaging is often used. We do pelvic ultrasounds. That way we can look at fibroids. We can look for any abnormality of the lining of the uterus. There's a very detailed ultrasound that we frequently utilize, and it's called a saline infusion sonohysterography, a big long word for a fairly simple test. We refer to it as SIS, and we put a little bit of saline up inside the uterine cavity, and it just makes the walls of the uterus separate just a little bit, like putting a puff of air in a balloon. So that we can evaluate the lining to see if we see any evidence of polyps, abnormal thickening, or any other abnormality of the lining. The reason you want a complete evaluation is that even though a woman presents and says, "I'm having vaginal bleeding," we may find that that blood is actually coming from the bladder or from the GI tract. And obviously the treatment for those are very different than if she truly is having abnormal bleeding that's coming from the uterus. The treatment all depends on what we found. If we found a polyp, then we would recommend that we remove that polyp. That's usually done with a fairly straightforward procedure called a hysteroscopy. A hysteroscopy is a D&C with looking. So we stretch open the cervix, we insert a thin lighted tube, just like a woman would have if she were having a knee scope or a gallbladder removed, but we look up inside the uterine cavity. We can see the polyp and make sure we can remove it. Also, if she had a fibroid that was impinging on the cavity of the uterus, we can also remove that many times with a hysteroscopy. A progestin-containing IUD can really be very helpful to a woman who is having heavy bleeding once we have evaluated her for non-malignant causes for her bleeding. In Europe, it's been approved for many years, and in the United States now several years. Other treatments that we can also offer women is something called endometrial ablation. That, in a woman who's through having her children, we go in and we destroy the lining of the uterus. And 80 to 90% of women who have bleeding problems, particularly heavy bleeding, will be very satisfied with the results of the endometrial ablation. And of course, ultimately, hysterectomy may be necessary to treat a woman's bleeding problem. But we are very fortunate in that we have lots of other modalities that we can offer that have a very good chance of success before we do get to the point of discussing or recommending hysterectomy.